Good morning and good evening or good day to all of you, wherever you are in the world. It's my pleasure to welcome you to our webinar on rural healthcare issues and opportunities in post-COVID world. So I'm Dr. Nitish Thakor, an alumnus of IIT Bombay and a professor of biomedical engineering at the Johns Hopkins University. And I should say, well, I'm proud alumnus of IIT Bombay, a distinguished alumnus, and also honorary professor at IIT Gandhinagar. I'm also among the founding members of Wheels and a pan-IIT technology review magazine we call PiTech. Both of these initiatives were born out of many events, conferences we organized back in Washington, DC in 2005. And as you see, we produce a number of different magazines featuring technology, innovation frontiers, rural transformation, sustainable transformation. All of these are the key features and key activities of Wheels. In fact, this magazine was presented to President Kalam as a way to feature IITians' accomplishments and work, and we are very proud of doing that. But okay, we are here now to talk about Wheels. So Wheels offers a technology solution to scale efforts for water, healthcare, energy, education, rural livelihood, and sustainability. This is where the solutions do not exist, and we encourage research and development at the IITs and other similar institutions through sponsorship. We work collaboratively with partners like IEEE, ISV, CII, Mission Samriddhi, Sevak, Spoken Tutorials, and others. Fantastic set of events. Lately, we embarked on an integrated approach for smart village development as an example, where entrepreneurship is the core of making these projects sustainable. So a brief introduction of Wheels was presented to you prior to the start of the events, and you will see that repeating. So please note all the accomplishments of Wheels. We are a volunteer organization and depend on the generosity of many donors. And we believe that scale can only be achieved by leveraging technology. So you can get additional information at our website, wheelsglobal.org or wheelscharitable.org. So please contribute generously in whatever way you are able to. Now, please, moving forward, let's acknowledge the generous grant from Smita and Ashok Siddhanti of Eng'g, Inc. It's an environmental health and safety consulting company based in Washington, DC. And both Smita and Ashok are long-term supporters of the Wheel activity, and they serve on the board of trustees and such. Now, I want to make a quick disclaimer. All views presented here by the speakers are those of the speakers and do not reflect, nor are they endorsed by Wheels Global and Charitable Foundation and its board and its members. Now I want to give you some housekeeping events so that the event moves smoothly. All attendees, you'll be on mute. You may ask questions to the speakers by entering it in the Q&A box. If you need any help, you can chat with one of us by raising your hand and typing your request in the chat box. We'll try to answer if we can. You can also send questions by email, info@wheelsglobal.org. And a recording of this event will be available on our website and on YouTube and Facebook. Questions from audience will be curated and channeled by the speakers and by myself. Okay, so let's come to today's event. Today's event, the webinar is on healthcare. Our goal is to explore technologies that will aid and assist in offering services in rural areas where there is limited or no access to hospitals or medical doctors. Now, for this, we have 3 highly respected and experienced speakers and an eminent individual, Mr. Arjun Malhotra, who I will introduce shortly. And all these 3 eminent speakers are committed to healthcare and philanthropy. We'll hear about ground level realities from them on trenches in US and India, how doctors in US have employed technology and entrepreneurship, and how they are currently working both here and in India in areas like artificial intelligence, machine learning, as well as medical diagnostics. Our goal today is to answer a number of questions. For example, Dr. Raj Shah, who is a pioneer in the field of telemedicine, will talk about how technologies can improve quality of healthcare. Dr. Thakor Patel, who has done incredible work in services in rural India, will discuss role of nutrition, diet, healthcare, and introduce Sevak, an organization he leads. And then Mr. Amit Khare will introduce telemedicine and his accomplishments in preventive healthcare practices. But now it's my pleasure to introduce our moderator, Mr. Arjun Malhotra. He is a distinguished alumnus of IIT-kgp. We are so proud to know him, and his participation in so many IIT and Wheels events. He's a gold medal awardee and a distinguished alumnus of IIT-kgp. He's also an alumnus of Harvard Business School Advanced Management Program. He is an Indian entrepreneur icon. He founded from his garage the HCL group, or co-founded it. And then it's built into one of the largest IT companies in the world. And subsequently, he went on to found other companies such as Headstrong. And then, of course, he continues to serve India and IITs. And he serves on the board of Indian School of Business. He's a great philanthropist. I give you a very good example. He has endowed scholarship at IIT-kgp in the name of his teachers. And that's honoring our alma mater and our teachers. He's currently, or he was a chairman of TIE Global and Global Pan IIT. But he's also, I'm so impressed, he's co-founded Spik Meke along with his friend Kiran Sheth on Indian music and culture to promote that among our youth. He is the vice chair of Wheels and chairman of Board Vision 2020 of IIT. Just so many accomplishments. So now it's my turn to hand over the event to Mr. Arjun Malhotra, who will introduce, he will make opening remark and introduce the panelists. Arjun, please take over.
Thank you, Nitish. Thank you for that very, very kind and elaborate introduction. I guess anything I do, I'll go downhill from here, but thank you again. You know, rural healthcare, after I sold, we sold Headstrong to Genpact in 2011, I decided to spend my time basically in trying to leverage technology, which is probably the only thing I know, and try and provide better healthcare outcomes to the economically underprivileged in India, especially the ones who are remote in rural areas. Now, any of you or all of you who've been to India and lived in India and know any doctors know that they're all completely overworked. I mean, every doctor I know, and I grew up, my mother was a doctor, and so I grew up in medical college campuses my whole life till I finished college. Basically, they are overworked, they were overworked. And if you look at what's happening in India, with the economy picking up, more and more people are coming into the healthcare system. I understand the numbers are increasing by 12 to 18%, depending on the economy. But the number of doctors is only going up by some 4%. And if I need more doctors today, if I invest today, they will come to me 10 years later. So the problem of doctor shortage is only going to get worse. So if we want to provide doctor access to people in the rural areas, we have to find a way of giving the doctors more time to be able to talk to them. And really the only way to do that is through technology. And so what I think people should be doing is looking at where doctors are spending non-patient facing time and actually finding out how we can give them technology or how we can leverage technology to help them see more patients, save that time, and use that saved time to see more patients. And basically, it's, a simple example, if you go in the US, where I've lived some of the time, and you go to see a doctor, the nurse does your triaging. She takes your temperature, your blood pressure, and then the doctor comes in with the results and spends a lot less time with you than he does here in India. Because here in India, the doctor does most of the triaging. In the US, they only do it if they want to reconfirm something the nurse or the nurse practitioner has done. So why can't we take something like triaging and get it done before it gets to the doctor? But that's not enough. With the amount of shortage we have in India, shortage of doctor time we have in India, we'll have to find a way to use or leverage artificial intelligence, which is available today, to try and do some level of diagnostics and help the doctor. I'm not going to talk more about it because I'm sure our panelists will have a lot to say. They've done a lot of work in this area. They are, in different parts of the world. But I think what we develop in India, or what we can develop in India to help our rural population, is going to be applicable not only in all over Africa, all over developing countries, but even in rural areas in America, where I'm sure there's a shortage of doctors. They may have better connectivity than we have, but that problem would still be the same. So with those very brief comments and giving you some idea about the problems that we face in the rural areas. And by the way, before I go on, I do want to say that the government of India has done a phenomenal job in terms of some infrastructure. We have public health centers, we have community health centers. They are there, they can be improved, they're not fully manned, they don't have all the equipment. But more importantly, we have an ASHA worker in every village, we have an Anganwadi worker in every village, and we have an auxiliary nurse midwife who is shared between 10 or 15 villages, depending on the population. And so we have people who are supposed to take care of your health and nutrition, and to some extent, the medical requirement that the nurse midwife, auxiliary nurse midwife does. And so we have that basic infrastructure. Unfortunately, as happens in a lot of government organizations, they each maintain separate databases or registers in this case. They are supposed to combine that information, but you can imagine if I'm maintaining 11 registers and I have to meet every 2 weeks and then match the data, it's going to be fairly inefficient. And so there is an opportunity there for technology to come in and make that synchronous for everyone. I mean, just giving tablets to them where they enter the data will make it really simple. So we do have some real advantages in India. We also have another advantage in India, that we've been fighting pandemics or epidemics for a long time. A lot of you have heard of our malaria eradication program, our polio eradication programs. And so we do have some kind of infrastructure that helps us when there's a pandemic and we aren't in the kind of crisis that countries like the US or Brazil or some of the others that you heard about happen today, although we are having our own problems with this present COVID crisis. Having said that, let me now introduce you to our first speaker. Our first speaker is Dr. Raj Shah. Dr. Shah, I go through a brief introduction. Dr. Shah is a pioneer in the field of telemedicine. He's a doctor with multiple specializations. He teaches, he's an entrepreneur. He's done a lot of work in that area. He's also got an MBA. So I think he can give you a very complete picture of what they have been able to do what he's doing, and they've been able to do in the area of telemedicine in the US, and what work he thinks we can do in India. Over to you, Dr. Shah.
Thank you very much, Arjun. It is a great pleasure to be here with you and very distinguished group of alumni, IIT people, to be able to bring doctor's view and technology. I know you have, Arjun, seen medicine from your technology vantage point. I have seen technology from my doctor's point of view. And believe it or not, leveraging technology is a common theme and a passion for me. So we are at the same wavelength. And let me go ahead and bring up my presentation. All right. How can I go back? So as Arjun introduced, today we're going to be talking specifically about the rural healthcare and issues and opportunity in COVID-19 world. So before we talk about healthcare, let's talk about what do we mean by health? I know it's so basic. We only think about health when we are sick. But really speaking, according to the definition by World Health Organization, health is a state of complete well-being, not just physical, but mental, socio-economical, and not merely the absence of disease or infirmity. So with that thing in mind, of course, if we talk about the mental and socio-economic well-being as part of the health, it will take us days and months to discuss. So today we're going to focus on the physical health. And this physical health, which is affected, particularly during this pandemic, being sick and how to restore by providing care. Of course, the physical health also requires prevention to remain in good health by learning the personal hygiene, good habits, diet, exercise, nutrition, etc. So let's look at this little video to highlight what issues
in the past week, we have seen a rapid escalation of cases of COVID-19.
Could this be something that spirals into a large lethal pandemic?
World Health Organization declared the outbreak an international public health emergency.
This is like a flu on steroids.
Throughout history, healthcare has been delivered in person. However, cost, convenience, and geographical barriers often pose challenges for patients to access healthcare. So many patients are not able to see a doctor or healthcare provider.
So as you can see, the issue is access. And the 2000 years of our traditional way of receiving healthcare or giving healthcare in person has a lot of problem, particularly during this pandemic day, when there is lockdown, there is restriction of travel, not available transportation, and quarantine poses a serious challenge how a doctor can deliver the healthcare. And particularly this problem is magnified in rural area. In our rural area, almost 70%, 800 million population of India lives in rural area. And with the shortage of physicians, there are only 27% of total healthcare providers are actually there in rural area, serving 70% of the population. So you can see the problem of accessing healthcare in rural area is highly, highly magnified and critical. Many of the hospitals, the primary healthcare centers, other facilities are without doctors. Only 30% of them without doctors. There is not enough medicine. There's not enough supply. And when it is there, the affordability by people is limited. If you just think about it, the per capita income of rural population is just about $600 a year. So it is difficult. Also in rural area, geographic and weather barriers causes a great issue for going in person and receiving or giving care or receiving care. And obviously infrastructure, roads, transportation, telecommunication, internet, all being scarce in a rural area causes a great challenge. So how rural people can receive care, how doctor can provide the care. So let's look at what comes to the rescue. And here it is. Technology comes to the rescue. Technology means art and skill, and logos means science. Is a science which provides us the tools to solve the problem. Now, mankind, beginning of mankind from Stone Age onward till today, it is the technology and the technologists who have provided the means to the mankind to improve their life, and particularly in healthcare area to remain healthy and have our longevity, which was 100 years ago was close to 40 years, now doubled to 80 years. So the tremendous progress in healthcare and maintenance of healthcare is given through the technology by providing clear, and not only just in medicine, like providing us the different modalities in ultrasound, MRI, CT scanner, nuclear, blending technology for pharmaceutical, molecular engineering, and genetic engineering, vaccine productions, new medication, just list goes, literally everything that we have today, which has made our life comfortable, is owed to technologies. So my friend, the elite technology group, that it's my pleasure and privilege to be amongst you and meet you virtually today. And my hats off to you for giving medical people what they need. So let's see how technology will come to aid to us to deliver healthcare, particularly in rural area. And that will be leveraging technology. And Arjun, you just mentioned leveraging technology for healthcare delivery, and particularly during this time when traditional in-person healthcare is so difficult to give it to rural people, we leverage technology, use technology to deliver healthcare. By doing so, we will, and creating remote online visit, we eliminate the problem of the access by making it more convenient, providing quality care, and lower the cost. How am I going to lower the cost when I understand technology is going to cost us? But if you think about it, in-person care, where there's bricks and mortars and ancillary support staff and other things required, compared to that, technology cost is so much less. So overall, we lower the cost of healthcare delivery. And video visit in majority of medical issue can be evaluated and treated, delivering quality care. So this telemedicine, creating video visit and provide delivering care is the way where we can help patients during this pandemic, particularly in the rural area. The technology, I know telemedicine is now a buzzword and COVID has necessitated and everybody knows about it. But really speaking, we physicians and patients have been using telemedicine by telephone for the last 100 years. There we only can talk, but now with advent and progress of technology, with video visit, digital devices, which allows us to not only just talk and see the patient, but actually examine the patient to increase our diagnostic accuracy. Technology has been a passion for me. It began during my fellowship days in 1973 at University of Pennsylvania, where we were doing trans-telephonic pacemaker monitoring, whereby you put a receiver mouthpiece on the patient's chest who has pacemaker, and at the other end, we recorded cardiogram. That was fascinating. And that kind of led to my way, how can I bring in technology to deliver healthcare more efficiently, remotely, and make it more convenient for patients. So this has helped me, and with my passion and vision, with help of my technology friend, Paul Ratnaraj at Wharton and Pankaj Khare, PK we call him, who is a IIT Roorkee graduate, and the business leaders, a friend who has helped me, Dr. Michael Cooper, who is an entrepreneur and an academician, a retired dean from Keynes University, as well as Professor Usim, who is the head of the entrepreneur section at University of Pennsylvania. That helped us to create a simple yet comprehensive telemedicine system we call this SmartCare. So let me bring that to your attention. This I'm presenting as an example what a telemedicine system, a simple system, how it can help us to deliver the care. The device, as I said, it's not just the video visit where you can see and talk to patient, but also we have integrated the devices. These devices are allows us simple devices, stethoscope, blood pressure, pulse ox. They allow us to not only see and talk to the patient, but examine the patient. And during examination, it is live and real time. We can continue talking and seeing the patient and continue to examine, just creating a similar workflow and situation as we do it in person, replicating online. As I said, telemedicine is a tool. It complements the in-person visit. It does not, mind you, it does not replace our usual in-person care. But when needed, we can provide the care, and it can help us to take care of the downtime that doctors have, and make it convenient, because they can do it on their downtime, and also by that way they can increase their revenue. And this tool is not just useful for the allopathic medicine as we see it, but also for our holistic care, Ayush, which stands for Ayurveda, Yoga and Naturopathy, Unani medicine, Siddha medicine, homeopathy, and any other way a healthcare can be delivered. We can use this tool by video visit, telephone call, by integrating devices to examination of the patient, uploading the reports, images, videos for consultation, for second opinion or review. But the system can also be used not just for the acute care, but also for the chronic care, follow-up post-COVID, taking care of chronic diseases, remote monitoring, screening, tracking, data collection, analytics, which can follow and predictive algorithm for AI, also treatment, compliance, and monitoring, but also for preventive care, which keeps us healthy and remain healthy by training, by teaching video, increasing health literacy for personal hygiene, good diet, nutrition, exercise, meditation, and the habits. So it can go a long way as an armamentarium for physician and for patient to receive healthcare wherever they are, whenever they need, without any geographic barriers, without any time barriers, without any travel and loss of productivity. So this, and I'm sure there are many other systems and other different ways which will be discussed by our speakers during this panel, how we can utilize for different aspects of healthcare and healthcare delivery. So now let me go to my last slide, the factors which are affecting telemedicine adoption. Just before COVID, only 20% of people even were aware of telemedicine, aware that technology can help us to deliver care. But COVID suddenly has necessitated, because we cannot provide in-person care, the technology leverage healthcare delivery. And the adoption has skyrocketed in last 6 months. And now telemedicine, which was obscure, is now a household, a buzzword. Of course, when I discuss factors affecting, these are the barriers and opportunities in disguise. So I ask my technology friends to look at it and help us, help medical profession to overcome some of these barriers and the factors which can lead to widespread telemedicine adoption, not just in the rural area, but everywhere universally. We need tools, devices, digital devices, computers, laptop, this connected devices, make it available to rural area and everywhere. Make it affordable. Remember, I told you, the income of rural people in particular is less than $600 a year. So if your system costs $500, it's just not possible for them to have it. We need a easy to use and navigatable software in multiple languages. We need software and hardware support and maintenance and infrastructure for that. We need users training, hands-on, online, by video, by spoken tutorials for doctors, patients, ancillary staff, and ground force. And particularly, as Arjun mentioned, Government of India has created ground force in ASHA, which stands for Accredited Social Health Activist. They are available in every village to go to house to house. And Sevak program by private enterprise, which will be discussed by next speaker, Dr. Thakor Patel. Scheduling platform, infrastructure, of course, telecommunications, cellular, internet, roads, etc., would be a government undertaking, but it could be government and private undertaking. And make sure that doctors and providers get adequate reimbursement for telemedicine service. And on a happy note, Government of India has passed regulation on March 25, came up with the telemedicine practice guidelines. And I think this will go a long way to make telemedicine as an important armamentarium for healthcare delivery. Thank you very much.
Thank you, Dr. Raj Shah. Thank you very much for giving us these details that need to be done. I'm sure both Dr. Thakor Patel and Amit Khare will be happy to try and address some of these issues. It is now my pleasure to introduce our second speaker, Dr. Thakor Patel. Dr. Thakor Patel, I mean, I can go on for a day if I have to give his full introduction, but you have the bullet points on the screen. He is a doctor with multiple disciplines. He is worked in the Navy. He's a naval officer. He is now an adjunct professor teaching in Bethesda. He's also now working with the Department of Veteran Affairs. His passion is and was to try and help rural India. And he is the founder of the Sevak Foundation, which is a unique way in which we provide healthcare services to people in rural parts of India. I will stop there and let him describe what he's doing and how he's doing it. Dr. Thakor Patel.
Thank you, Arjun. That was a very nice introduction. And I want to thank all the participants and the attendees to take time off and attend the seminar. As Arjun said, one of my passion is the Sevak project. We started the project in 2010, and it is a project which is Gandhian in nature, which is healthcare for the villagers, of the villagers, and by the villagers. It is based on the US Navy model of independent duty corpsmen. Corpsmen are the medics that we train for about a year and put them on various warships. they could be the sole provider of healthcare on these ships. And at that time, I thought that a ship is like a village, contained population. Why not train somebody from the village to look after their own healthcare? And that's how this whole project was born. Now there are 33 districts in Gujarat, and we have over 100 villages, because in each of the Sevak can do his own village, but can go to the adjoining village. And the education level is about 10th to 12th grade level. They live in their villages, their own village, and they screen for diabetes, hypertension, and they collect a lot of data on their environment, habitation, income, family health care, etc. And they're also required to educate the village folks about the merit of having in-house toilets, smokeless stoves. We started this project by doing some studies in the United States and India, which determined that we really need a project like this, Sevak. And one of the first thing I did was to get permission from the Chief Minister of Gujarat. And I spoke to him for about 30 minutes. And at the end of it, he says, do it. And that picture was my permit, because he didn't give anything in writing. But one of the good things about that meeting was, this tells you the character of the Prime Minister. He doesn't believe in sending you to his Commissioner of Health or Health Minister. It was him, that's it, just do it. These are the states that we have the project in: Gujarat, Bihar, Orissa, and Tamil Nadu. Sevaks live in the village, and the philosophy behind the Sevak project is, if you have somebody in the village who is doing the project, he has ready access to all the people. They know him, they will trust him or her, because we do have about 10 Sevikas also. And we started with blood pressure, diabetes screening, as I thought it's easy to teach the Sevaks on how to do it. And data collection, I already mentioned. We do collect data on vaccinations. And if the children are not vaccinated, the Sevaks educate them on why it is important. We have found many new diabetics and hypertensive patients. I'll show you the slides later. And they're referred, our referral base is primary health clinic or the patient's own doctor. Special cases are identified by Sevaks and they're referred to cities, in some cases, the Sevaks accompany them. We had one from Mehsana that went to Ahmedabad and stayed in the city for 2-3 days. They also know houses without toilets, and I pushed them to get toilets through government grants. Today, over 85% of the families have in-house toilets, and some have over 100%. We have also built 10 RO plants. This has been a great partnership with Wheels Global Foundation. And the Wheels water track is run by Mr. Rohinton Mehta, who is a big supporter of this project. And through him and Wheels, we have done 10 RO plants. In one village, 250 out of 1,000 people had kidney stones. After the RO plant was introduced or installed, only 12 are left with kidney stones. And in another village, Wales and Habitat for Humanity helped build toilets, reaching 100% of the villages. Sevaks were trained also by CETI, which is collaboration to eliminate TB in India. And Sevaks go house to house. Since they go house to house, they can identify somebody with productive cough and refer them. Another project is Maternal Child Health. All girls from age 11 to women 40 years are screened for anemia using Touch HB machine. If they have a hemoglobin level below 10, they'll be treated by PHC ASHA workers. We are also looking at fortifying family food with iron. breastfeeding is very important part of newborn baby and a child. So Doctors Padmini and Rupal Dalal have been at the forefront in this. And there is a tutorial by spoken tutorial on this. These initiatives will help decrease maternal child morbidity, mortality. Now, coming to telemedicine, telehealth, many of the PHCs are not staffed adequately. So telemedicine may be the solution for this critical need to prevent patients having to travel to cities. In India, somehow, even in villages, if it is 5 kilometers away, it is still difficult commute. But there are other people in the village who help other patients. In big villages, over 10,000 population, telehealth with Sevak training may be a viable option. Sevaks form the foundation for preventive health, and with training, other health solutions can be implemented. I'll go over some of these very quickly. This is a touch HB machine which looks like a camera. She's looking at the conjunctiva, and that's how we find out what the hemoglobin level is. Then in COVID era, we had all the Sevaks go online and get certified by the government certification program. This is the anatomy class. We teach them anatomy because these are people from all walks of life. And you have to really brainwash them into thinking medicine. This is our Sevak seminar in December, a group of Sevaks. This is our Sevak Training Center, which was sponsored by Wheels Global Foundation and Mr. Roynton Mehta. This is the training center. This is an anemia chart. We have the Sevaks look at this chart and compare with the Touch HP machine. These are some of the Sevaks at work. This is in Banaskantha, in Sabarkantha district. A Sevak, we have Acer computers with all the Sevaks, which is again courtesy of Wiz Global Foundation. And they were the ones who introduced me to technology and said, you really need to use this for data collection and teaching. And that has been God's sent. She's the only 10th grade Sevika we have. She's in Kutch, but very bright and very hardworking. This is one of the persons donated money to me, and we found somebody who needed the food in Kutch. This is a Sevak in Tamil Nadu, in Bihar. Now there's a story. He's an electrician, 42 years. Sevak brought up this issue to me. This is its toilet. Now imagine triple amputee and the use of this toilet. We had him build this toilet in 1 week. This is an insulin-dependent diabetic with about 400 blood sugar. But look at the location of where the insulin is stored. And we bought small refrigerators for all the insulin-dependent diabetic in the Sevak project. This is another Sevika in Mutakalawad. And we have an RO plant where we sell the water for about 5 rupees, 20 liters. We have Sevaks that have been trained in how to save children's lives below the age of 5. And I already talked about the RO plant. We have also installed a sanitary napkin manufacturing plant in Mutakalawad to create jobs for local women. But this brought up a whole new issue of women hygiene. And now in the Sevak project, we pay a lot of attention to this. In Navalgarh, we installed sewing machines to create jobs for women. We are looking at how to do cancer screening in these remote villages. This is the sanitary napkin manufacturing plant. And this is the sewing center. We actually had to hire a teacher. This is some of the data. We screened over 100,000, but we have data on 60,000. Look at the education. This was important because if you look at the education of the villages, it's very low. So anytime you want to introduce even change in health behavior, it becomes a very difficult thing. But the Sevaks have been able to make inroads. In one village, the Sevika was called BP Ben. And income level, most of them are farmers, it's very low. Overweight and obesity and overweight is not a big problem there. We have 4.5% patients who are diabetic, 2.83 did not know. And 8.5% have high blood pressure. Most of them didn't know they have high blood pressure. Now, how to help? If anybody wants to help, you can go to Will's website or sevakproject.org. And the way to help is by identifying the need in your village or state of origin and finding the candidates who would like to do the Sevak work. There is a stipend for the Sevak as an incentive. Sponsor the Sevaks. It is very rewarding. There is no overhead. And I personally feel blessed to be a part of the Sevak project. This is the website for Sevak project. The second website is my personal website. Thank you.
Thank you, Dr. Patel. Thank you. And that's some great work that's being done in those villages, in those states. India is a huge country. We have something like 600,000 villages. So a lot more work has to be done. And while we do make a difference by doing this in small parts of the village, we have to ensure that they are sustainable, that they will continue to do it. And I think education, as Dr. Patel mentioned, is a very, very important part of what we're doing. Now, I take pleasure in introducing our third speaker, Mr. Amit Khare. Amit, I've known Amit for a long time. We've been colleagues in my earlier life. Amit is a technologist par excellence. He is a computer science engineer, comes from a family that has all doctors. He's the only engineer, which is really what motivated him to get into technology that will help the medical profession, basically. He was the program manager at Oracle, where he ran a fairly large group all over the world. And he's been working on his company, EVOLKO, since I think 2007, 2008. He has a number of very interesting solutions that are specific for India. And so without taking away any of his thunder, I hand you over to Amit Khare. Amit, all yours. Amit, you're still on mute, Amit.
Hi, thank you, Arjun. Thanks for the offer to speak. I want to start with recognizing the effort put in by Arjun in promoting IT industry in India. And his example inspires every entrepreneur. And I am fortunate to know him personally and being part of the EVOLKO journey. My name is Amit Khare, and I am CEO and co-founder of health tech startup EVOLKO. At EVOLKO, we have a mission to make technology improve the clinical outcome and make us proud. We are building the patient care solution that we recommend to our parents and loved ones. And that is the commitment to our reliability. What keeps us awake is that there are needy rural patients who are not able to get timely help. I visited many villages and I found one common question. People ask, may I get a help from an oncologist or a cardiologist? They have patients, they have relatives, they all want a specialist care, but it's non-existent there. So they want some method, some way to get easy access to them. And even if they get it from the village, by going to the cities and all, if the problem comes next day, they cannot just pick up a vehicle and go back to the city. So those problems are there, and that causes the delay causes more complications and often mortality. There are more patients in the world than the doctors who can treat them. The shorthand of the Indian healthcare system is that they focus more on the acute episodes of illness and not actually screening and monitoring the patient. And that has been recognized by the Niti Aayog in their December 2019 report. In addition to the lack of these facilities, the things that complicate is that the number of doctors are increasing at a far slower pace than the number of patients because of the economic changes and all those things. So if we take a look at it, and if we see that, okay, it may take about like 2 decades or so to get to the number of doctors, and which is like a WHO recommended doctor to patient ratio. But we have the technology available today, and if we use the technology, we may solve the problem today. So what we can do is, if we make the screening and triaging of a patient mandatory, it would solve 3 objectives for us. First, the doctors would get a pre-triage report so that they can spend more time in explaining the treatment and explaining the consequences of compliance and all those things to the patient than actually spending time in asking questions. They have very limited time, and we need to see how they spend their time. The triaging and screening builds the medical baseline for the patient, so that in future it could be compared against whether the treatment is improving or it's not improving the condition of the patient. Just by doing the screening and triaging the patient, a lot of information about the patient is gathered. The machine on the back end starts analyzing the data, and with analyzes, it can figure it out whether the patient is carrying a risk of heart disease or diabetes. And those are unassociated, because the patient may have come only for the fever, but finally when the analysis came, it may come up that they are carrying non-communicable diseases, one or the other form. And I'll talk about it in my further slides. So the way the screening and triaging works is, it asks multiple choice questions from the patient and in their native language. So the reason why we choose the native language is because patient can precisely tell what is actually going on. It is captured at that level. And we have like a better set of patients who can interact with the software. So these questions are not like fixed type of questions. These questions are the response to one question decides what should be the next question for the patient. So it's all interactive and highly dynamic in nature. But most of the patients, if we see, may or may not be able to interact with the software so easily, especially in the rural area that we want. So what we want is these patients to interact with our telemedicine operator. So that's the intermediary operator who interacts with the patient and take down their information and give it to the doctor. And that way, patient gets whatever they want. They get the details from the doctor, and their ailment or their condition is taken care of. These telemedicine operators, they are financially self-sustaining. The model is financially self-sustaining because they take like a few rupees from the, about like a 30-35 rupees from the patient. So it is not dependent on any grant or any subsidiary or donations. So they can continue to work on their own with the initial investment of their kit and all. The way we induct the telemedicine operator in our process is that we go to a district, and on an average, there are about 1,000 villages in a district. So we get these awareness campaign over there. People come to know about, like, okay, what's the TMO program, how it can help their patients, and some of the people come forward to become telemedicine operator. And these people are not, we don't expect these telemedicine operator to more than what a high school student knows. So that's not a big requirement as far as the education is concerned. And once they understand how to use the software on a mobile phone, we send them to a hospital training. And in the hospital, they go there and they triage, they screen the patients. So some of the hospitals where, especially the medical college hospitals where we work with, we get about like a 5,000, 7,000 patients a day. They undergo this screening. So these telemedicine operators get trained at about a 50 to 70 patients in a day for their practice and taking the vitals and all those information. And that helps them build up the confidence to go back in the village, set up their center, and start working. So that's how they get trained. And we it's a pretty comprehensive program, and we make sure that they have an experience of minimum 500 patients before they go and start their work in the villages. So there are challenges as well. We face challenges like internet availability in the village. Some villages get like a good internet connection, which are nearby the big city or town. And then the more deeper we go down, the internet becomes flaky, and that's a concern. Sometimes the travel which is required from the village to the center, to the hospital where we do the training, it's a very long distance. So we try to make sure that in the vicinity, within the 100-kilometer range, we have some hospital where the triaging going on, so we can train them adequately. Last but not the least is the kit, telemedicine operator kit that they buy, which includes the 6-lead ECG, the blood pressure meter, a printer, and Android phone, and all those things. It costs about like 35,000 rupees, but it is high for the village person to buy. So that's where we take help from the NGOs and take help from the government also to make sure that they are able to start their operations. We have about 6 studies that I want to discuss, and what are observations from these studies. We ran few online health camps, and these health camps were without any doctor. So there were health camp, about like 200 to 300 patients came in each of those health camps, and they were totally online. So they were, for treating those like 300 patients, about 15 doctors who were specialist doctors sitting remotely in the city while patients were in the village. The advantage that we got is that they still, the moment the software figures out that, okay, this requires a intervention or the advice from an endocrinologist. So we had the endocrinologist on the other hand helping out the patient directly. So patient gets very credible and timely advice over there. Then by collecting all the data, and then when we analyzed the data, we figured out that patient, even though they came for knee pain or a cervical pain, or maybe just like for their recheck of the tuberculosis and all, but the data shows that 34% of the patients were unaware of that they were carrying some form of risk of hypertension or diabetes. And that is, as we as I can tell you, that they had absolutely zero idea, no idea about that they had these diseases, and we referred them to the specialist later on for the detailed follow-up and detailed treatment plan for that. Second study is that we did with the cardiology department of King George Medical College, where we did a randomized trial. And in this randomized trial, we had the patients who were from the acute coronary syndrome. And after getting their angioplasty, these patients went back to their villages and they were monitoring their symptoms and details directly on the system. So the system was capturing details of their well-being, blood pressure, and all those things, and they were all facilitated by the telemedicine operators. And the data, when it came to the cardiology department, they were actually analyzing on a daily basis what is going on with their patient, and if there is any refinement needed in changing the medication and all, they were able to do that. In this trial, half of the patients were put on the health radar and being monitored on a daily basis, and the other half were on a routine follow-up, whatever is going on. And the advantage was that the BP control was like much better in case of patients who were being monitored very closely by these doctors. So that was very encouraging statistics that we got. Then there are PHCs and CHCs in rural or at the block level. What happens is these PHCs and CHCs keep referring patients to the higher centers for any need of a specialist because they do not have any specialist over there, not even in the CSCs. So, and the patient definitely incur a lot of inconvenience to go all the way to the city. So what we did, we collaborated with medical colleges, the tertiary care centers, and we said, okay, those patients would be screened in the CSCs and PSCs, and the information will be electronically sent to the medical colleges or the tertiary care center. They can take a look and advise whether to send the patient or not to send the patient, or if the treatment can be taken care of over there as well. They had some ICU rooms and all those. They put the triage machines over there to triage the patient, and that helped a lot because doctors started saving time. The thing that they can do it in a few minutes was taking like much longer for them, and that is the advantage of asynchronous communication as well. Then All India Institute of Medical Sciences, Patna, they started our telemedicine operators program, TMO program in Bihar with 59 telemedicine operators. That was back in 2017. And for 1.5 years, they ran this program as a study. And in that program, about 88,000 consultations were done, out of which 55,000 patients were provided treatment, and the remaining were asked to come to the hospitals because the remote treatment was not possible. Then they compared a lot of data, their travels and their expenses and all those things, and they came up with the figure that on an average, a patient saves around 2,000 rupees in out-of-pocket expenses. And if you multiply it by 55,000 patients who were out there, so total about 11 crore rupees of saving in out-of-pocket expenses from the bottom of the pyramid. The other observation is from the rural maternal health monitoring and education. What we noticed is that monitoring some of the parameters which are very critical to infant and maternal mortality. So if we monitor a few things very carefully, it is possible to reduce these statistics in a much better way. I'll give you an example. Just by monitoring the weight of the pregnant lady, if the rate of growth is less than normal, that it indicates like IUGR, which is known as intrauterine growth retardation, and that could lead to the infant mortality. If the rate of the if the weight growth is getting more than normal, and that may indicate like gestational diabetes or a bigger than normal baby, which could again be a problem because there are lung complications and all those things happen if that happens. So these are the, and if the, because by monitoring and all those things, we can reduce the chances of maternal and infant mortality. It's a very satisfying experience, and patients also feel very, very happy to use this program, and we got a very good ratings by the patients. We talked about how things have worked in the pre-COVID era, and how it will be working in post-COVID. But we are during the pandemic right now, where the TMOs cannot go directly to the patient for the risk of exposure for the patient and for the TMO both. For this, what we did is we started an eTMO program where the TMO is actually taking all the screening and triaging data using his phone and calling the patient on the other side. So over the phone, they take all the details of the patient. The only thing that they cannot do is taking vitals, and in some cases where our vitals are absolutely necessary, then TMO has to meet. There is no other option. But patients started getting the advice from the patient, from their doctors, and the eTMO program worked as well. With that, I want to thank you all again for listening it, and I'm sure we will come out of the pandemic shortly and safely. Thank you very much.
Thank you, Amit, for a very enlightening conversation and information. You know, India has, the problems are huge. I mean, I don't know if you're aware of the scope, but we lose something like 1 million children a year between the ages of the time they're born and the age of 5. And a large number of these can be saved. So the problem of infant mortality, the problem of malnutrition, and you know, mortality is one problem. Stunted growth is another problem, which just doesn't stunt the child from a height or weight point of view. It also stunts the mental growth. Some of our speakers mentioned the problem of menstrual hygiene with women. Some 75–80% of the women in India use rags. Now, while it is not a killer, it is debilitating, and you know, it sort of impacts their efficiency, how well they feel, how good they're feeling. And so there's a lot of education to be done. There's a lot of things that need to be done in India that we are doing. I have a lot of questions for the audience, but I just wanted to, before I get to the questions, I just wanted to say, I've been looking at the comments and the questions that people are putting up on the chat. May I suggest to the organizers that if they could give everyone, at least I'm happy to give my email ID so that if people have questions, they can come to me. And I'd really like to share with you in more detail some of the work that all of us, that I know is being done in this particular area. There are people making machines that can give you a blood reading in 6 minutes while you're right there. And the big advantage in India, I think Dr. Raj Shah talked about cost. Our volumes can get our costs down if we accept the SaaS model, which is now very popular in software. So we really can do a lot of things that we want to do in India just because we have the volumes. I think the other thing you must keep in mind is that while telemedicine seems to be the solution, doctors have a limited capacity. In fact, I know working with Amit that both at AIIMS Patna and at King George Medical College, now it's University in Lucknow, they have a capacity of 2,000 telemedicine consultations a day. Yet there are people who need more than that if we put telemedicine locations in every village. And so now we are trying to work a scheme where we're trying to get private doctors and Ayush doctors to come in and help do that consultation. I think it's amazing. The other thing is, just the way India is, when I have a telemedicine operator, it's not just a male. I have to have a female there too, because women will not come to a male, especially if their vitals and all have to be taken. That's just the way we are, and I can quite understand it. So there are lots and lots of things that need to be done in India. And as everyone said, technology is the only way we'll partially solve it. I'm not even sure we'll be able to fully solve it. I have a lot of questions that I want to ask, but I know we are running short on time. What I will do is turn this over to our chairperson, Nitish. If you could take over and give us questions from the audience, I'd rather we answer their questions than answer my questions. I can catch the panelists later and get them to answer my questions.
Thank you, Arjun. Thank you. Yes, first of all the speakers, just incredible presentation. I should tell you that chat room is saying a lot of congratulatory comments, and you should be proud of your work and all the ideas you have presented. So I'm going to narrate a few questions. We have limited time, so I'll start with Dr. Shah. The question here is, you operated telemedicine clinic in a Walmart back in 2012, going that far back. So I'd love to share your experience with telemedicine and also how it can be presented from homes or nursing home. Give us some example if you can.
Sure, it's a pleasure. We were the first in America to open a freestanding telemedicine clinic where we piloted leasing 2 clinics in Walmart store in Philadelphia area. Over the time, we saw more than 1,000 patients who would just walk in and doctor will come online. There is a receptionist who will take the patient, take the vital, put the data, and notify doctor to come online. Almost 100%, well, that will be, so I have to say 99.9%, they were highly satisfied. They were highly appreciative, even though some of them had initial trepidation that, oh my God, there's no doctor and come online. But when they left, we had a survey and unanimously all of them loved the way they were treated. They got what they wanted. And from the doctor's perspective, we validated the system, accuracy, the ease of using, and effectiveness at a lower cost. When just in America, average cost for office visit is $100, we were able to do this at $59 for each patient. We presented this data to American Telemedicine Association, the largest organization in the world, in 2017, and we got the first prize. So that was the concept beginning. We took this further, how else we can utilize. Because the system is small, just a laptop and devices, we took it to patients' home. And we got a contract from a large health insurer to take this patient to patients' home who cannot travel to the clinic or doctor's office and would need to go to emergency room for costly treatment. We send a assistant to patient home, saw patients, provided complete service, including their examination, treatment, etc.
Ask a quick question. How would this kind of carry over to Indian context, again, in cost and technology? And maybe you can end with maybe your wish list for the technocrats.
Sure. The India is incredibly creative. bringing this thing to a cost where we can place this thing, maybe a smartphone in every villager's hand, or maybe a unit of laptop with devices in any small area or a clinic that will allow them to have medical care through a specialist or a general doctor from the primary healthcare centers, community, or city hospital. That would be a great way to bring the care right down to that. Now you asked me the wish list, and I have a wish list for all my technology people. I want the cost of devices to be very affordable for villagers. I want this software which is easy to use and navigatable easily. I want an infrastructure to support them. I want a devices, particularly innovation, where I can do a virtual touch. I can touch and feel patients and provide even a next step to that. I want pocket MRI. I want, so a list goes on, but that's my list. And I would love to talk to any technocrat who is interested in helping to bring this to the—
Let's do that. Just like Arjun's kindly offered to connect with everyone, I hope you will too.
Sure.
Dr. Thakor Patel, there are just so many questions for your work that you have done. And like first one is, how can anyone join the project or help set up at local level? And even at a community level, if you have set it up, or can somebody help you do that?
Now, what we'll do is we'll try, first they have to identify the village and a Sevak from that village. And based on the number of Sevaks, we'll hold a class in Baroda. The reason for Baroda is because I have an infrastructure there. We'll train them and then send them back. And the initial cost is not that much. It would be a cost of a laptop, which is about 20,000, glucometers, strips, blood pressure machine, things like that. And we'll train them. And once they go to their village, they start collecting data, they start going house to house, and we'll jointly work with them. In light of that, one person near Khambat has trained 30 Sevaks in 30 villages. And that's how impressed she was with the Sevak project. But now she runs the project. We don't have anything. And if she has any technical issue or wants more trained, we'll do it.
I just got a very interesting question that there are 10,000 trained hospitality workers have reverse migrated to villages. Can we reskill them, and can we utilize their help?
Yes, they can. That's easy. Those would be easy to train. So if somebody sponsors them from that area, then it can be done. You have to have a sponsor, because India, for example, is so diverse. From United States, we think India is one country. No, India is many countries. And each state that you pass, it's different language. I went to Tamil Nadu and I didn't understand a word. But we have Sevaks there. So there is a sponsor, there is a coordinator who knows English. That's how we communicate.
Well, that's great. Again, there are just so many questions, but a couple of them you can address. One about micronutrient deficiency, which is a huge problem, like iron and iodine. Other one is about using Tele Retinopathy for eye examination because of diabetes and any other questions. So how can you?
We already have Tele Retinopathy in the Sevak project. We have a camera that Dr. Vikas Khurana sponsored. And so we trained the Sevak to do Tele Retinopathy with an ophthalmologist backup. So that's one. And the other thing is, what was the next one you said?
Well, it's micronutrients.
Yeah,
like
micronutrients. I mentioned about iron deficiency in girls. We screen them from age 11 to 40-year women and supplement them with iron. We are looking at adding some vitamins to that.
That's great.
Nitish, if I may just expand on Tele Retinopathy. In 2016, we used our system and integrated a non-mydriatic camera to take pictures without dilating pupil at Temple University in Philadelphia. Mostly diabetic patients, unless something is wrong with their eyes, they don't go for the routine checkup, where diabetic retinopathy is the second largest cause of blindness. Because when they go to the eye doctor, they get pupils dilated, spend an hour, get their picture, and then rest of the day they're useless because they can't focus. Having this small, either handheld or a camera, which can take the picture without dilating pupils, thanks to our technology people for that invention. We now take the picture, and in just 3 months after installation, instead of 5 people going for a routine exam screening, we had 500 people, and that was written up in Forbes magazine as one of the creative way of using technology for patient betterment. And now there are more than 3,000 patients screened at Temple University over the last 3 years. So
it seems
something like this, where technology can make a huge difference.
Yeah, consistent message, and maybe that's a good way to turn to Amit, because I was impressed how he started off with his phone-based and make a strong case for AI and machine learning and interactivity. That you had this fantastic robotic triage. So I have a question for you, how are these ideas of you can apply to gather data rapidly and affordability, because India is like a vast pool where data and information can come through the technology and media that you have created, which can then decide where the healthcare can be delivered. So maybe you can comment on that.
So what actually is happening, the way we address this issue is we are going to the hospitals which are having many thousand patients per day. And what happens, for example, AIMS are getting over 5,000, 6,000 patients per day. King George Medical University gets about 12,000 per day. Then another one, Balrampur, gets 8,000 patients per day. And when these patients come, each and every patient goes through this triaging exercise. So we start getting data build up. I mean, we have a very minuscule size of the data that we have, about 8 billion or odd patients that we have so far. But it is growing rapidly as we move from as we are progressing. We see that doing the complete screening of the patient, irrespective of what disease or what problem they come for, and that's how we are building the baseline of those patients and building the information about the.
You seem to be getting a number of questions. In fact, all the speakers, Dr. Shah also, how can we help you scale up? That seems to be a little bit of a consistent question from audience. And maybe you can start and we can cycle back to the others.
Well, scale up requires accessibility of the devices and software and the support structure, and cost. It is the cost is the driving force to make it scalable. Just give you an example. If you guys did not come up with PC and handheld devices, then IBM mainframe, which cost millions, Watson said that, oh, there are 5 computers, that's enough for the world. Think about that. Look at the blood pressure machine. In 1970, when I started, graduated from med school, it cost $500. Today, you can buy it for $30. Now, every household has a blood pressure unit, pulse ox. And so bring down the cost, make it easy to use, and put it in everybody's hand. That will change the landscape of healthcare delivery.
Yeah, I'm going to ask Amit and later Arjun, because you guys are the industrialists, technocrats, and how this can be handled. So Amit, you can start, and then Arjun, you can also share about this sort of scale up and scale down and cost reduction of computer technology. So Amit?
So there are 2 ways that we attempted to scale up the process. One, and which I think is an important one, is giving the facility in the hands of the people, directly patients. So we compress the whole triaging program, put it into the mobile phone, and put it in the application, so patients themselves can do the self-triaging and send the information back to the doctor, because that scales up easily, and it is not held up by one person sitting there in a hospital and doing one patient at a time. The second is, which is going to the medical colleges or going to the hospitals, which gets lots of patients. So that is where the bulk of the patients will get screened, and things will progress accordingly. So these are the two methods that we are applying right now, and we are thinking of like scaling in a better way or in a more faster way.
Maybe Arjun, you can also share your wisdom.
No, definitely. I had a couple of points. One is the volumes in India are so large that you can talk about, it's like why did PCs, why do things come down in price? When you make 200 or 500 or 1,000, there's a particular price of components and of assembly and stuff like that. When you make 1 million and 2 million, the numbers come down substantially, right? And that's India. So we need someone to come in and commit, because it's going to happen, it's needed. That's number one. Number two, even certain instruments where the price is high, like $30 for a blood pressure machine. But if I can get 100 people to use it every month and charge 10 rupees per use, that's very affordable. And so because we have people in India, I can actually equip one person with this kit and let him go door to door in a city too, not just in a rural area, in a semi-urban area. And that person earns money, the kit manufacturer earns money, everyone earns money. I also want to add one more point, that it's not just people who understand medical technology or who know hospitals or stuff. I'll give you an example of what we did at AIIMS Patna. When we were doing work with them, they were just starting. I noticed at least, a lot of the patients, not a lot, nearly all of them were coming in autos. Now, when you're in Delhi, you don't see patients coming in autos. They come in ambulances or they come in cars. So I sort of asked the question, and I was told that Patna, crowded streets, narrow streets, ambulances and cars can't get through, but autos can find their way. Like cockroaches, they'll find their way through and get the person in. So what we did was we wrote an application in Hindi, which the director of the AIIMS, the institute, went on a couple of weekends and got every auto driver, and everyone has a smartphone in India. They cost 800 rupees. At least the auto drivers have them. He downloaded the app on their phone. So now if you're in Patna and you have the app, and let's say you fall down and break your hand, and you press the app, one option is I am injured. You press I am injured. The minute you do that, the guy who's looking at where you are knows your location. He knows the location of these 10,000 autos. He'll call an auto near you and tell him to pick you up and get you to the hospital. It's an Uber application, if you look at it, but used in a completely different way. So I just want to tell technologists that it isn't only the medical solutions we need in India. We need solutions in everything. The 108 system that works in India is a technology solution. So, when you want to solve the problem, it's just not medicine. It's just not that doctors. We have to find a way of, making things happen, getting people to where they have to get to quickly. And I gave that example only to tell technologists that there are lots of applications that exist today that can be adapted very easily to be used in India. And of course, India invented the word jugaad, and that is exactly what you've got to do to make this thing work.
Thanks, Arjun. So I will go to Dr. Thakor Patel, and then I come back to you for some of the closing comments. So Dr. Patel, it's taking on that theme of dissemination, outreach, scale up. We are in this COVID era, and how are we going to get both diagnostics and vaccines down to the cost and large-scale dissemination in India? And how can we, audience, Wheels, help?
Yeah, all the PHCs already have vaccination program. And that would be the starting point for rural India. And Sevaks work with the PHCs. So if the PHC needs help, they can ask the Sevaks. And ASHA workers are there also, who can take patients to the PHC and get them vaccinated in the COVID vaccination time. But the basic thing is distance, masks, sanitation, those are very important. Fortunately, the villages are not that affected.
Yeah, Arjun, so I request you to take over and perhaps summarize or make your closing comments.
Yeah, you know, instead of summarizing, I think everyone's heard what everyone had to say. I made some comments, and I think in some ways, this whole COVID problem is a blessing. And, you know, I hate using that word with COVID in the same sentence. But the reason I say it's a blessing is because I hope governments all over the world take this as a motivation to upgrade and change their healthcare systems from what they are today. And really, you know, I made 5 points and I'll read them out. I think today's healthcare system is a break glass system. It's like you have a fire, you break a glass, and then the fire alarm starts. I basically think that we have to have an always on system, that the system doesn't have to break a glass. It should be always on, so that as soon as we have an outbreak or any real problem, dengue or whatever, we can react immediately rather than having to break glass, as they say. I think the second part of it is that, you know, today we have uneven disease surveillance. Like we do dengue during the monsoon season in India. You know, we don't monitor everything all the time. I think, again, we should upgrade our healthcare system, strengthen it at a national and local level so that mechanisms to detect infectious diseases are in operation all the time. So again, this will be effective detection, and then we can build our capacity to manage them accordingly. I think that's the second change that countries have to make in their healthcare system, and this will require prioritization and investment. The third thing is we are waiting for outbreaks. We are waiting for this pandemic to happen before we did anything, waiting for malaria to happen before we do anything. I think what we need to do is have an integrated epidemic prevention agenda. It should be integrated. And again, you know, the benefits are obvious that if it happens, you have like a disaster recovery team we have. If you have a natural disaster, we should have something similar in the healthcare area for pandemics and epidemics that happen. I think finally, what's happening today, you're running short of ventilators, you're running short of ICU beds. There's a scramble for medical capacity. That should not happen. That should never happen. In fact, systems should be ready to surge while we have these kind of problems. So we don't have to, you know, come into this situation that we have right now. We need to make sure that we design systems so that we can expand very quickly rather than running out of capacity as we did this time. And last but not least, I think what we have to do is that we have underinvested in our R&D for infectious diseases. I think the world has to get together, and this is not a country's problem. It's not an individual's problem. It's not an India problem. It's not a US problem. It's not a China problem. It's a global problem. And we have to collaborate on making these vaccines and getting them ready quickly. It's not a I did it first, so pat me on the back and I'm better than you. You know, I landed on Mars before you type of problem. I think the world has to change how they look at these things and try and put it up. And I hope this pandemic motivates people and people don't forget too quickly. And I hope it makes our healthcare system much more robust and better. And that'll help not just urban, but even the village health. In fact, it'll actually help our rural health care a lot if we can get something like that done. I just thought I'd end with what I thought we should do instead of trying to summarize, because I think everyone's heard what everyone said.
That's thanks a lot, Arjun. And, you know, audience, I apologize. We cannot come to so many of your questions. Some of you made some fantastic suggestions. I believe they are going to be documented. So it's time to now wrap up and kind of thank the audience. And also I want to really convey our appreciation to Arjun, you for chairing this program and coordinating and sharing your wisdom. Dr. Patel and Shah, you are clinicians who have done both entrepreneurial and service work. Your comments were so insightful. And Amit, similarly, you have done this incredible work in both technology to its scale up and translation. It's time to thank a number of volunteers who don't get to be seen and shown here, who made this webcast and everything happen, facilitate Q&A. The Wheels team, I mean, they are working tirelessly and selflessly to make this operation on behalf of IITs, Pan IIT in India happen. And it's really, we just need to thank all of you. There are going to be a lot of takeaways from this webinar, which we will also collate, and some of them will be displayed at the end as a video. But I'll try to kind of summarize. I'll start with Arjun, right? I mean, I think you started with this 1 million children a year. I mean, the scale of need for infant mortality, stunted growth, women's health, it's kind of just so overlooked and so essential. If our women don't have health, our children are stunted, how does India and we all move forward? You made a strong point for the doctor shortage and needs, and there were a lot of comments concerning how to address that. But clearly you and Amit and others made a comment that we really need to leverage technology, and Dr. Shah also made that same point, that technologies get to work. And of course, Arjun, you said that let's not scramble, let's be ready for now and future at a scale-up level. Dr. Shah, I mean, you talked about physical and mental and socio-economical health. And, I like your quote, you said, technology comes to the rescue. And of course, you talked about the smart clinic, smart video, smart opinion tool. And so they are useful now in COVID pandemic era and maybe beyond. And again, you made the case that please technocrats come to rescue and come and help. Dr. Patel, I mean, your Sevak work is just so such a model. There was another suggestion, there's an ASHA program. So it's been a model for a lot of programs. You've shown the way to cover, like your work kind of went to thousands of villages, and you touched things like diabetes to hypertensive to hemoglobin levels. Your work has gone to other countries, Guyana, Morocco. So I hope everyone will pitch in to help you scale up further and continue your work. And you gave us the connection to Sevak project that I hope people noted. Amit, I come back to your comments about AI and machine learning based screening, that robotic triage, and perhaps, you mentioned about TMO operation during pandemic, ETMO. So, to me, it seems like the way to go, and it's so critical right at this moment. I kind of want to end with Arjun's comment that we should not be motivated by pandemic. This is where it's happened. This should be an ongoing thing. And he made a strong plea that we need to invest in R&D, but also that world has to come together. This is not us versus them. It's a global collaborative. And I believe that's going to be so critical in the question of diagnostics and vaccine dissemination to India and other countries. I really feel like, many in the audience belong to professional society, like for medical, API and AMA. Engineers belong to society like IEEE, and of course, many here are IIT alumni. So please engage your society in this action. And maybe each one of you in the audience, you can ask the question, what role can I play? I mean, these three speakers and Arjun are your role models, and they've done immense thing. I think they need help for sure, but maybe you can step up and work through Wheels. So, Wheels is, I hope, your vehicle. So please donate. You can donate money, donate your time, volunteer. Okay, so to wrap up, I think you'll know that today's events will be all on the website, as well as perhaps at the end, we will continue to play some of the slides. And so you can refresh your memory and get involved. Wheels will continue to have other webinars. In fact, if you go to the website, you will see several of impressive ones and impressive speakers contributed. We now have an upcoming webinar on August 21st, similarly 10 a.m., 7:30 p.m. in India. It'll be about role of professional organizations to address the issues and opportunities in post-COVID world. And very distinguished panel, Dr. Jonalagarada, President of API, Dr. Ramesh, who is a candidate for IEEE presidency, Sandeep Srinivasan, who is the president, Penn IIT Alumni USA, Krishan Dar, president of Penn IIT Alumni India, and Suresh Chennai will be the chairman and moderator, and Vikas Khurana, Dr. Khurana will also join on behalf of Wheels Global. So the theme of that will be COVID-19 related pandemic and global impact, health, economy, and national and local governance, and how it will be managed. Okay, so in the interest of time, I'll wrap up and thank again all the attendees. Really our distinguished speakers for very enlightening and very heartfelt and selfless work that you all have done. Please join us in a couple of weeks, and I hope we will continue this good work that has started by Wheels and our speakers. And again, please volunteer, please contribute to Wheels. Thank you all for joining.
Thank you, Nitish. Thank you, everyone.
Thank you. Thank you. And my hats off. Saras. Very good, Aksaben.
Good.
Good.